would you normally expect?
About 35. So between the two co-hosts.
And are most people medics or neonatal nurses as well, or I normally expect?
About 35. So between the two cohorts. So we have a mix of mostly senior grid trainees, international neonatal fellows from a variety of different countries, Belgium, South Africa, India, Kenya. We've got colleagues from the UK, some of my consultant colleagues, and nurses from Southampton Neonatal Unit.
Fine. Very good.
So 3 live portals. So the colleagues interacting from the neonatal unit watching you over YouTube, and the colleagues basically who are part of our neonatal ethics course basically interacting with you directly. So they can actually interact with you directly. And then our network is basically watching you via my co-host.
Wow, it's very complex.
Jassim has also just joined us.
Alok, you there?
Yeah, Jassim, I can hear you.
So then you'll handle the meeting, isn't it?
Yeah. I'm happy.
Yeah. All right.
We just have a few minutes if you want to grab a glass of water, Professor Wyatt, or...
Okay. Yeah, I will do. Thanks for the opportunity.
It's really kind. Thank you so much. Just starting to pick up now. So I'd like to welcome you all today to a session that is very close to my heart. And I would like to introduce you to Professor John Wyatt, just to give you a brief overview. So when I came to the UK, Professor Wyatt basically taught me how to do cranial ultrasound. And the course that I attended in UCL, I still have the 2 books that he's actually published with the images, which I still use to actually train my trainees today. But in terms of the tenets and the kind of points that I've taken home from those sessions still stay with me today. And I can't emphasize enough how useful those pearls of wisdom are that we get from colleagues, with much whiter hair than we have at the moment. I'm hoping my hair at some point will become a little bit more white. So with that, I'm just going to give a little bit of an introduction. So Professor Wyatt is an ex-professor having worked in UCL in London, who has a special interest in ethics and medical ethics. And again, he's been very kind in supporting us over the years in supporting our sessions on neonatal ethics at our neonatal ethics conference, and has educated thousands and thousands of neonatologists, but a lot of health professionals from lots of backgrounds, multidisciplinary education delivered to both nurses and doctors. And I think there's not enough that I can say about how much we've learned from him over the years. Clearly today, he is going to give us a little bit of an educative talk on IVH prognosis, contemporary outcomes for children with IVH, but with a special focus on how we communicate when we're trying to talk about prognosis, what we say, the challenges from our perspective in such, and the changes that have occurred with time. And I think that's something that I'm really keen to get a view from. I'm a consultant who's quite young. I'm only 10 years into my clinical practice at this particular point. And the ability to be able to hear from people who have, had decades of experience of talking to parents, it's irreplaceable. So I would like to welcome you all to just some etiquette with the talks. So all the talk will be divided into 2 sessions of 30 minutes each, with question answers after 30 minutes. Any questions should basically be put through to the moderator via the chat function, please, so as to avoid talking over each other. Everybody is currently muted. And I just humbly request that you don't unmute yourself until the question answer session is live. So without further ado, I'm going to hand over to Professor Wyatt.
Thank you very much, Dr. Sharma. That was a very generous introduction, and it's a great privilege for me to be part of this session. And I just want to try to make myself available in any way as a resource person. So very happy to engage with any issues you'd like to raise. I must say I'm feeling very much my grey hair. I'm now been out of the directly clinical scene for a number of years. I'm still actively involved in the field of medical ethics and in writing and teaching about technology. But for many years, I worked as a consultant neonatologist at UCH, and we were particularly interested in the use of ultrasound. In fact, UCH was one of the very first places in the world that started doing cranial ultrasound. And in fact, the story as I heard it was that when they first started using cranial ultrasound, it was just after the first CT scans of babies had occurred. And as you know, a CT scan produces an axial picture of the brain. And therefore, once they came across this with this new transducer to get a picture, the natural thing to do is to hold it on the side of the head and to try and get an axial scan. And I understand that the team at UCH were trying to take these axial scans and not seeing very much and staring at the screen and saying, oh, I think I can see the ventricles and so on. And after several months, one of them said, hang on a minute, there's this hole at the top of the head. Why don't we try putting our probe up there? They put the probe on the fontanelle. All of a sudden, they could see an image. And it was literally that kind of trial and error. So they were one of the very first places to start getting ultrasound images. And one of the very insightful things that my predecessor, who was Osmond Reynolds, who was one of the great pioneers of neonatology, he said, what we need to do is start a prospective follow-up study of premature babies. And what we will do is we will record the ultrasound scan, and we will then follow the children, the premature babies, all the way through childhood, and work out what is the objective relationship between the ultrasound appearances in the first weeks of life and the long-term outcome. So I'm going to share my screen now, and so that the follow-up study that I'm my work on, and I became part of it when I joined at UCH in the 1980s. But it was actually set up in 1979, and the aim was to define the relationship between ultrasound and the neurodevelopmental outcome. And I'm going to focus on the results from the UCLH study. I mean, there have been a whole number of other prospective follow-up studies doing similar kind of studies, and they've all shown very similar findings. So although there are slight differences in outcome, they're all basically showing the same message. But if we just look at this particular, now quite an old cohort, they recruited all infants less than 33 weeks, and they were followed up all the way through to 8 years. So, and in fact, the study continued, and even today, there are now adults who are in their 30s, ex-premature adults, who are still being followed up. They're having MRI scans, they're having detailed psychiatric assessment and psychological assessment to see how that very early ultrasound pictures, how they relate to long-term outcome. And the decision that was made, and I think it was a helpful decision, was that instead of just trying to describe the lesion and then remember what all the different outcome figures were for different lesions, that for clinical use, the best thing to do is to just use this rather simple division of the ultrasound appearances. And so there's low risk, there's high risk, and then, you know, because in medicine you always get this sort of ragbag in between, which are not one thing or the other. So if we start first of all with high risk down here, a high risk ultrasound scan is where you end up with loss of brain tissue. So, and that's either cysts, such as a porencephalic cyst, which is what you would expect after the so-called grade 4 hemorrhage, or occasionally what you can see is obvious global atrophy of the brain. And not surprisingly, it turns out that if you actually lose brain tissue, this is permanent loss of brain tissue, then you come into a high risk category in terms of outcome. And then looking at the data, the other group were the low risk scan, and the definition of a low risk scan is either where the ultrasound appearances have always been normal. So one thing to emphasize is that in order to assess the ultrasound appearances, you need to do more than a single scan, obviously, because a single snapshot can be quite misleading in a baby, in a very premature baby. And the ideal is to do repeated scans, particularly in the first week of life. In fact, our protocol, although it was a sort of standard of excellence, was to do daily scans throughout the first week in order to see the evolution and the changes of the lesions in the brain. And then following after that, we did weekly scans until discharge. Now that may be too much. Obviously, you need to decide in your own setting and with your own resources what would be appropriate, but that would be the optimum, to do daily scans initially and then weekly scans. And the risk category comes from how the scan evolves. So if the scan remains normal throughout the whole period, then that would go into the low risk scan. But what our data showed was that if you had an uncomplicated hemorrhage, and that means a hemorrhage which appears, intraventricular hemorrhage or a germinal matrix hemorrhage, and then resolves and goes away, and the brain scan appears normal after that, then that also comes into the low risk category. Thirdly, if you just have parenchymal echo densities, but nothing else, and they don't go into cysts, then that would be a low risk scan. And finally, if you have mild degrees of ventricular dilatation, I want to emphasize this is not talking about hydrocephalus, but it's where you look at the ventricle and you can see that the ventricle is definitely dilated, but to a minor degree. That also comes in that low risk category. And then you get this ragbag group, which is the intermediate risk category. And when we looked at the data, what became apparent was that if you had 2 or more of the low risk lesions, you came into that intermediate risk. So for instance, if you had both an uncomplicated hemorrhage and ventricular dilatation, then your risk goes up. Or if you had, for instance, a hemorrhage and a flare, your risk would go up. And the other category is where you have hydrocephalus, which is stable, but there is no cystic changes. And so that often that means that's a hydrocephalus where a ventricular peritoneal shunt has been inserted, or otherwise it's spontaneously stabilized, but there is no clear loss of brain tissue. That also comes into that intermediate risk category. So when you look at a cohort of extremely premature babies, or very premature babies, in fact, this cohort is everything less than 33 weeks, so it had quite a lot of the more mature babies, you tend to find this pattern, and that is that the vast majority of babies come into the low risk category. In our study, it was about 75%, 3/4, and less than 10% came into the high risk category. And then you had about 20% in the intermediate risk category. You know, it's very important to remember this as neonatologists, because it's when you practice neonatology on a NICU, the babies you tend to remember are the bad babies, the babies who have terrible brains. And what you forget are the large numbers of babies who sail through with low risk brain scans and who do extremely well. And so it's just important to remember that balance. Actually, the ones who have really bad scan appearances and high risk scans is a small proportion of the total. And then we followed up all these children, and we threw the book at them in terms of both neurological assessment and also developmental assessment. And we basically looked for children who had any kind of detectable abnormality on testing, and we described that as an impairment. And then we looked particularly at those who had a disabling impairment. That means something detectable which was causing a significant reduction in overall function. This is important, again, just to understand these definitions, because there's a lot of confusion about what we're talking about. So for instance, a child who you see at 8, an ex-prem child, and who on examination definitely has abnormal tendon reflexes, say some clonus or something like that, would go down as an impairment, even if they are walking completely normally and mobile and able to run and jump and so on. Nonetheless, they have a detectable abnormality on neurological examination, so that would be an impairment. If, on the other hand, they had significant motor difficulties, that would go down as a disabling impairment. So, for instance, cerebral palsy of any kind would go down as a disabling impairment. Similarly, somebody who had an abnormality, for instance, of eyesight, of myopia, but which was correctable with glasses, would go down as an impairment, but it wouldn't be regarded as a disabling impairment unless it was actually interfering with their life. So, here is the crux and nub. If you look at the prediction of outcome of 8 years and concentrate on this column, because this is what parents are interested in. Parents aren't interested in whether the tendon reflexes are normal or not. They're not interested in whether you can pick up some subtle abnormality. What parents are interested in is, will my child be in some way disabled? And the answer was, if you've got a low risk scan at 8 years of age, there's a 6% chance of a disabling impairment. Contrast that with a high-risk scan where you've got a 74% chance of a disabling impairment. Now, just also remember that when we talk about a disabling impairment, if you talk about a disabled child to a parent, the most natural thing is they will think of a child with spastic quadriplegia in a wheelchair. That to them is their image of what a disabled child is. It's important to realize that when you look at these statistics, they're not necessarily talking about that degree of impairment at all. They're talking about, a child who had a monoplegia with one arm, for instance, that was significantly reduced, would go down in this kind of outcome as disabled. And so it's important, again, to help parents to understand that disability covers a complete spectrum of outcomes ranging from absolutely catastrophic through to relatively mild and something that the child can cope with remarkably well. So that just it shows it. If you look at the question of extra educational provision, this is what our statistics show at IQ. Again, it shows that the low risk scans have a 17% of extra educational provision. The high risk scans have a 75% chance of extra educational. So again, same kind of picture. If you've got a high risk scan, you have definitely a high risk of having a requirement of educational difficulties. And again, if you look at the IQs, you can see a definite relationship. But the important thing to remember is that these, and look at it, these SDs are very large. That's just one SD. And so what it shows is that some children with a high risk scan will actually have a normal IQ. And some of them may even have an above normal IQ. And we certainly saw children like that. So just to go back to this summary slide, what we see is that the ultrasound risk categorization done in the first week or two of life is highly predictive of what happens at 8 years of age and on into adolescence and so on. But some children, even with a low risk scan, some children are going to end up disabled. In other words, having a completely normal ultrasound scan does not mean you can guarantee that a child is not going to have disability and a premature baby. And similarly, this is not 100%. In other words, even if you've got a high risk scan and you've got loss of brain tissue, you've got a cysts or something like that, you may actually be normal. 25% have not got a disability, and 10% have absolutely no detectable abnormality on examination at 8 years. And the fact, therefore, that although ultrasound is helpful, it is by no means 100% predictive. That's a very important message when we come to talk to patients. The other thing to remember is that even term babies, if you have a term baby born in your hospital who has no detectable problems and who is discharged and goes home after 24 hours, what is the chance that that child is going to end up with disability? Well, it depends on your precise definition of disability, but it can be as high as 3, 4, 5%. In other words, the low risk category for prem babies is not that different from the general risk in the population at term. And that, again, is an important message to try to communicate. Following up, one of the fascinating things that happens in a lot of ex-prem children is its subtle white matter injury. And that's not the main reason we're talking today. We're talking about hemorrhage, but it's just a fascinating thing we saw. There's a lot of these babies had thinning of the posterior corpus callosum, and there are other subtle white matter abnormalities, which we increasingly recognize as something which happens in ex-prem babies. This was a study which, again, done in our cohort. This was done at the Institute of Psychiatry and some of our ex-prem babies, and they compared the grey and white matter distribution in adolescents who'd been born very prem at UCH compared with term controls. And interestingly, this is the grey matter up here, this is the white matter. And if you look at the blue areas, these are areas where the prem babies actually had increases in grey matter. And the brown yellow areas are whereas there was decreases. So there was decreases in grey matter in certain regions, but there were compensatory increases in grey matter in other regions. And this just emphasizes the fact that after the baby goes home from the neonatal unit, a huge amount of processes are going to go on over the following 10, 15, 20 years as the brain remodels, adjusts, revises because of the extraordinary plasticity of the central nervous system. And that then reminds us again that it is not deterministic. As neonatologists, it's easy to think, well, what happens to your brain in those first few weeks of life is going to determine the rest of your life. And it just is not as deterministic and mechanical as that. The brain is a constantly adjusting rewiring and has an extraordinary amount of plasticity. That's just showing the same. And this is another example of the kind of rewiring. This is a fractional anisotropy map, and this is a normal adult brain. And the green fibers are orientated AP in the front to the back. The red fibers are orientated across between the hemispheres laterally, and the blue fibers are orientated out of the screen vertically, coming up at us out of the screen. And that's the normal pattern in the adult brain. And as you can see, there's a huge amount of tracts communicating antero-posteriorly, this so-called ventral stream, which is thought to be very important in the way the brain normally functions. Now compare that, just keep that in your mind. This is an ex-preterm brain of a baby who had a grade 4 hemorrhage. That's an HPI, a hemorrhagic parenchymal infarct. And you could see there post-hemorrhagic hydrocephalus. So this baby has got grossly dilated ventricles, and on this side had an HPI. And I think you can see with a big porencephalic cyst, which is now in continuity with the ventricles. And I think you can see, can't you, if you compare that now, this is the normal adult brain. Can you see how the pattern of fibers, the way they run in this very damaged brain, are quite different? But the fascinating thing is that this ex-prem child had actually gone to university, had a unilateral hemiplegia, but above average IQ. So clearly, the brain had managed to rewire itself at plasticity in order to function at a cognitive level very successfully. This I've taken from a chapter that in an older version of Neil Marlowe's of Rabelton's textbook of neonatology. Unfortunately, it seemed to disappear from later versions of the textbook, but I found this quite a helpful summary because Neil Marlowe had just summed together from all the literature and these percentages who were so-called normal and those who were disabled. Now, of course, you have to interpret this with a great deal of caution because different studies use different definitions of disability. But the reason for showing this is that it basically shows the same kind of message that we got from the UCH study, that if you've got a normal scan, 92% are going to be normal, 5% disabled, according to Marlowe's work. If you had an uncomplicated hemorrhage, 88%, 7%, in other words, virtually the same. If you go back to intraparenchymal hemorrhage down here, HPI, then 38% normal and 62% disabled. So again, it basically shows the same picture, but again, notice that 38% in this study was so-called normal despite a grade 4 hemorrhage, which we would normally say was very bad news. And so it's so important to remember that these lesions are not as predictive as you might expect. I'm coming to the end of this section, but just before I finish, I would like to say an important point, and that is that as you get to more and more preterm gestations, in other words, as you get closer and closer to 23 weeks, 24 weeks, and so on, the normal scan becomes less predictive. In other words, as you saw previously in the more mature babies, the normal scan, the chance of having disability was low, about 5–6% in the UCH study. If you just look at extremely preterm babies, these are all less than 1,000 grams. In fact, a higher proportion of babies with normal scans have problems at follow-up. 9% had cerebral palsy at 18 months, and 25% had a cognitive problem at 18 months. So just remember that a normal scan in an extremely preterm baby is not as predictive of normality. And that's because it appears to be you can have very subtle abnormalities of white matter, which are not obvious on the scan. The scan basically appears normal, but which actually can lead to very significant problems in later on childhood. And when they looked in this particular paper to see what were the multivariate associations with cerebral palsy, this column, or with cognitive impairment, this column, what came out was being male. As we know, being male is bad for you at every stage of life, including when you're very preterm. Being part of a multiple birth, that's not surprising. Low birth weight in itself is independently predictive of poor outcome. Interestingly, for CP, mechanical ventilation seemed to increase the risk. When you come to cognitive impairment, it's other things like maternal race, maternal education, maternal insurance, this is from the States, became quite predictive of cognitive impairment. And then the last thing to say is this, and when I first read this, it completely blew my mind. But I think this is a very important message which is not communicated enough. And that is a study in which they took all babies who were born very preterm, so less than 33 weeks. And they simply looked at the effects of the parents' socioeconomic background with the long-term outcome at adults of these preterm babies. And what they found was that the parental education made a huge difference on the likelihood of having an adverse outcome in ex-preterm babies. So in the lowest parental education group, that was parents who did not complete high school education, 1 in 6 of the ex-prems had severe problems in cognitive and neurosensory functioning, and 2 in 5 had problems in everyday activity. And you compare that with parents who completed college education, so that's tertiary educated parents. Instead of 1 in 6, it's 1 in 14 have severe problems in cognitive, and instead of 2 in 5, it's 1 in 8 had problems in everyday activity. So what this shows is that the childhood exposure that this ex-prem is exposed to can have just as big an effect, even if more of an effect, than what happened in the neonatal unit. And again, as neonatologists, we tend to forget that. We think that what happens in the neonatal unit is the most important determining factor, but it isn't. It's what happens after the baby goes home. Now, why is this so important? Well, because this is a reason to give parents hope. To say the way you care for your child, yes, your child may have some problems, but the way you care for your child can make a huge difference over the subsequent years. You are the most important person for your child, and therefore you mustn't destroy hope. When we speak to parents, as we'll see, one of the most important things is not to destroy hope. So perhaps this is something we can discuss if you're interested in, and these are perhaps rather out of date, but I think you can use the cranial ultrasound scan in order to decide what kind of follow-up is required for your child. And if you have a low-risk cranial ultrasound scan, you can argue that because your risks are not that much greater than in the general population, you don't require detailed follow-up unless perhaps you're less than 28 weeks. Conversely, if you come in the high-risk scan, then I think you can argue that you should be immediately referred to a multidisciplinary child development team. You don't wait to see if the child is going to develop cerebral palsy or other difficulties. In fact, you should warn parents and say that right from the beginning, this child should be getting intensive input. You warn parents of long-term risk, but don't destroy all hope because you might be wrong. So in summary, neonatal cranial ultrasound is a valuable tool for the immediate management and long-term prediction of outcome of preterm infants. It can help to predict long-term outcome, but not all normal scans lead to a normal outcome, and not all high-risk scans lead to severe disability. And so our first duty as doctors is not to do harm. And it is possible to do harm just by the way we talk to parents. Primum non nocere, first, do no harm. Okay, thanks very much. I'm going to stop there. And I'm very happy to discuss anything that wasn't clear, to repeat anything, or to answer any particular questions.
So I'm gonna open questions to the audience. So would anybody like to ask Prof any questions? We have a few from the audience on YouTube, which I will ask Prof after the audience has gone first. So does anybody want to go first? So Anna, go for it.
Hi, thanks, Dr. Wyatt. That was very interesting. I just wonder, in terms of that last slide where you mentioned about the parents' education level, do you have any information about sort of the distribution of gestation in those, and whether it's sort of affected by the fact that people from a lower socioeconomic class are maybe more likely to have extremely premature babies, if you know what I mean?
Yeah. I mean, obviously, you're right. There is some kind of interaction there. We know that there is a statistical relationship between parental education and your risk of having an extremely prem baby. But I think this was something that was looked at in the paper. I think it's there, but it's not as strong. It certainly doesn't explain the findings. And you know, we know from experience that I've seen many parents with social class 1A backgrounds who had a baby at 24 weeks. So you know, it's certainly a significant number of babies who are born extremely prem do come from very good backgrounds. In fact, as I'm saying this, I'm just remembering a 23-weeker who I cared for a long time ago, from professional background, did very well, and is now at university, age 20, at 23 weeks. You know, so that would be an example of an outcome which was definitely positively influenced by what happened to her after she went home.
Thank you.
So anybody else have their hands raised? So, Prof, we have a question from one of the participants in the audience, and it's a fascinating question, and it's really looking at your experience, but just for extremely preterm babies who are breastfed versus formula fed, what is there any evidence on long-term neurodevelopmental outcomes being better for the breastfed cohort?
I'm not completely up to date on the most recent literature, but my memory of the literature is that there is some evidence of breastfeeding having beneficial effects. I mean, the beneficial effects of breastfeeding is partly infection resistance. The lactobacillus, bifidobacillus promoting factors in breast milk are extremely helpful in impeding other pathogenic bacteria like E. coli. So it's partly the anti-infective effect, and it's partly thought to be there are, magic components within the breast milk which are particularly promoting brain development and so on. However, the problem with breast milk is lack of calorie intake. Because breast milk is less calorific, less calorie dense than modified premature formula. And so paradoxically, we also know that calorie intake is a vital factor in long-term developmental outcome. And it's been shown quite nicely that the rate which the head grows in the neonatal period is quite predictive of long-term developmental outcomes. And so the babies who get chronically undernourished and who fall off centiles on the neonatal unit have an increased risk of having cognitive and developmental problems. So breast milk is not a panacea. And I remember from my own clinical experience that sometimes we found that it was babies who were having breast milk often didn't have the same kind of weight gain as babies who were receiving formula. So there is a place for supplements. Therefore, I think, unfortunately, when you use supplements, you often minimize the anti-effective effects of breast milk and the anti-NEC effects of breast milk, but you maximize calorie intake. So there's a kind of balancing process going on there.
So one of the questions that we have is that we often have scan protocols in the neonatal unit, and with babies who are extremely preterm, we scan them at birth, 3 days, 7 days, and there's additional morbidity that takes place with other comorbidities like NEC, late onset sepsis. And the difficulty for us becomes, quantifying what the head scan means in the context, not just of prematurity, but those additional morbidities. And I'm just curious how, in your experience, you pull those things together. So that might be pulled together in the context of wanting to stop intensive care for a baby who's obviously got very severe PVL, who might have very severe chronic lung disease, not coming off the ventilator, for parents who want to carry on, versus a situation where this baby is going home and is actually neurologically normal, and the conversations are so different. And it's something that me as a consultant with, just 10 years experience, it's something I really struggle with. And I'm just curious to know what your approach is in those circumstances.
Yeah, thanks. They're very interesting and challenging. This is where, medicine is not just a science, is it? It's an art. And we're trying to take all the information that's available and then use our experience and our knowledge and our wisdom to try to advise parents. And that's the real art. And it's by no means easy, but the way I think about it, both in my own thinking, but also the way I often speak to parents about it, and that is, I think of it like a jigsaw puzzle, that what we're trying to do is put all the pieces in place so that we can see the whole picture. And it's important to recognize that although different pieces are important, any one piece does not tell you the whole picture. And it's important, therefore, for parents to understand that, for instance, the scan appearances is one piece in the jigsaw, or maybe several pieces in the jigsaw, but it's not the whole picture. And often my experience was that parents often latched onto the scan, and they often latched onto what someone had said to us. Sometimes it was a junior doctor who said, "Oh, I don't like the look of that," or something like that. And it was like that comment became completely dominant, that the parents couldn't think of anything else but what one doctor said about the scan, and they get it completely out of proportion. So I think trying to help parents to see that in trying to look towards the future, and yes, we all have to do that, you try to build up a picture of all the different bits of information and pull it together. And so, for instance, if you're talking about a baby who's had a very complex history, where maybe they had, hemorrhage in the first few days of life, and then they had a bit of recovery, and then they had a massive collapse because of NEC, and they had and sepsis, and then prolonged chronic lung disease, and then they've eventually sort of got better. And now, if we look at the scan actually isn't looking that bad, and it's it's got some ventricular dilatation, but there's no obvious PVL cysts, So I've got to try and say, well, let's try and build up the picture here. Yes, we know there was some hemorrhage. Yes, we know that there was that bad episode of NEC. Yes, we know there's chronic lung disease and not prolonged oxygen requirement. But on the other hand, the brain is growing, the baby's growing. There's no obvious cystic changes developing on the ultrasound. And I would say I'm cautiously optimistic. I recognize that, yes, there is a small but significant chance that your baby is going to turn out to have problems, but I really don't think you should be desperately pessimistic and say, oh, it's all going to be terrible. And I think it's possible for us as clinicians to pass on our concerns and worries onto the parents. And frankly, you're not doing them any favors. You're filling their heads with a whole load of things to worry about, which isn't going to help them when it comes to caring for their child. What does a parent need to know? What they need to know is that what they do makes a difference, and that they need to be motivated and positive about the fact that they can do the best for their child. And that's why I think, although we can't hide risks, if people ask us what are the possible risks, we do need to emphasize the positive outcome. And I often used to talk about babies where had done so much better than I had thought. And that included babies with cysts, with PVL. I can remember one child who had a huge, great bleed into the temporal region and ended up with a big temporal cyst. We happened to have a visiting neuroradiologist, I think from the States, visiting the unit, and he looked at the scan and he said, "Oh, that's absolutely catastrophic. I've seen those, these children are absolutely damaged." And I remember I sat down with this mother and I did a sort of, what we used to call a black cap job. I would tell her, "I'm terribly sorry, but there's evidence of really quite severe brain damage." And in fact, this child, I then followed up this child in the follow-up clinic. I saw her repeatedly and she was completely and utterly normal. And there were no neurological signs. She was making normal developmental progress. There was nothing to find. And I felt really embarrassed because I could remember having, warned the parents. And I talked to the parents about that. And I said, "Look, I got it wrong. And I'm sorry because I fooled you ahead with a whole lot of really bad stuff. And it wasn't true." That, incidentally, this is why it's so important for neonatologists to go to the follow-up clinic. If you spend your whole time in the NICU and you don't actually see the children coming through the follow-up clinic, you are not going to be able to counsel the parents properly and realistically. And I think it's absolutely essential that neonatologists are actually spending time in the follow-up clinic, and not just up to sort of 6 months, but actually seeing children at 4 years and 8 years and school age and so on, and seeing what's happening to them, because it completely changed my view. Quite often I would be on the neonatal unit and I'd hear so many people saying, "Oh, isn't it terrible? We've got another grade 4 hemorrhage. Oh, it's catastrophic. Everything's terrible." I just sometimes wonder whether we should shut the neonatal unit and give them all potassium chloride. That kind of terrible fatalism. And I would say, I can't believe you're saying this, because I've just come from the follow-up clinic and I've just seen a whole succession of ex-prem babies, some of them with CP or with other problems, but actually they're living their lives and they're very, very grateful, and the parents are very, very grateful, and it's much more positive and life-affirming than what you sometimes think in the neonatal unit. So we've got to try and find the balance. But this is why I think first, do no harm. We can do a lot of harm if we fill our parents' heads with lots of gloomy prognostications going on and on. Oh, sorry, I'm on a pet topic here, but it's sometimes, I make the contrast. Imagine you're the pediatrician and you're doing the postnatal checks, and here's this term baby. And it's a completely normal, healthy term baby and about to come home. Imagine if you were turn to the parents and say, "Now you do realize, don't you, Mr. Smith, that your child has a 1 in 3 chance of getting mental health issues. I just felt you ought to know that. You do realize there's a 1 in 6 or 7 chance the child's going to need special educational help. You do realize that social deviancy is very common in adolescence, and you need to prepare yourself for that. You do need to realize this child might develop terrible, devastating illness. I mean, for instance, road traffic accidents is a very major problem in young children, and so on and so on." We don't do any of that. We would think it was utterly pathological to say that to a child, to parents with a term baby, even though all those things are true. And yet when we've got a baby born at 28 weeks, we say, "Oh, you do realize you could have educational problems. You do realize you could have cerebral palsy. You do." So why is it different? Why do we feel that with a term baby, our responsibility is to say, "Congratulations, she's a lovely baby"? Whereas when they're born at 28 weeks, we think our responsibility is to fill their parents' heads with a whole load of terrible, gloomy stuff.
So I've just got one last question before we let you progress. That's from Dr. Monica Kaushal. She's a consultant neonatologist working in the UAE. Dr. Kaushal, would you like to ask your question, please?
Yeah, thank you, Alok. Actually, I had put a lot of things in the chat box because what I feel is neurodevelopmental outcome is dependent on so many things which we are doing the NICU to these babies. So I was just wondering, do we have like any data where we can like separate them out and then say something like infections, so many infections and different kind of infection, the medications what we are using, and the impact of those rather than just ultrasound, because I've seen like, very happily we say, oh, baby, we are discharging a baby with absolutely no IVH, no PVL, and, everything is going to be very nice. And later on when we, I'm talking about the opposite what he was saying that, and later on when the baby comes for our follow-ups, he does have developmental issues, and that's why I'm just wanting to ask about these other causes which could lead to the neurodevelopmental bad outcomes. How do we have any data on that? And plus, I had a comment on the breastfeeding when we all know that exclusively breastfed these preemies would have low calories. And so when I asked about breastfeeding, I meant like you need to add HMF, and now we have a human HMF as well. Vice versa, when you're giving the same calories with the formula feed. So do we have such differences in the neurodevelopmental outcome?
Yeah, thanks very much. I mean, certainly, as I said, you must be aware that babies with completely normal scans can have quite bad outcome, and precisely why it happens in different cases is often very hard to explain. I mean, we do know that there are many factors that can happen in the neonatal unit which can interfere with brain development. And what is puzzling is why some babies seem to escape without damage and other babies can be quite severely affected. So we do know that sepsis, infection, certainly can affect developmental outcome. We know that prolonged mechanical ventilation just by itself has quite deleterious bad effects on brain development. We know even just being on oxygen by itself increases the risks of adverse developmental outcome. And I think it's also true to say that there's a growing evidence that the very environment of the neonatal unit, so things like, if you think how a fetus is, a fetus at 24 weeks is in this sensorily deprived environment, dark, quiet, protected from all variations. And you compare that with what it's like to be in a NICU, where you're blasted with light, you're blasted with sound. I mean, people have measured the number of decibels you get in incubators, and it can be enormously high levels, far higher than we would tolerate normally. You get touch. You think of all those negative experiences of heel pricks and cannulation, intubation, suction catheters, lots of adverse effects and sensory stimulation. And there is increasing evidence that in itself can have quite deleterious effects on the developing central nervous system. So the whole attempt, one of the things I got very interested in towards the end of my career was, whether it was possible to nurse babies in ways which had minimized these kind of negative sensory effects. But I think the honest answer is that in any one baby, it's usually impossible to work out what all these different factors, how they have contributed to the outcome. And therefore that's why, we need to be honest with parents when we're counseling them. We need to be honest that we can't predict the outcome in any one case. But nonetheless, my own view is it's better for parents to be too optimistic and then discover that actually their child has more problems. Well, as long as we warn them that it was possible, that's better than to convince the parents that the child is going to be absolutely catastrophically damaged, because I think that in itself can add a further damaging effect on the parents and on the child.
That's really helpful, Prof. Be very happy for you to continue your talk.
Shall I go straight on, or do you want to have a break now?
No, you can go straight on. Very happy.
Okay.
Yeah.
So we've already said actually quite a lot of what I want to say, but if we just go on to this next bit, and in many ways, you know, this is one of the most difficult jobs in the entire part of neonatology. I personally found counseling parents in a way which was both accurate and at the same time compassionate and gentle. I found that an extraordinarily challenging and perhaps the most difficult part of my job. It was much easier making the clinical decisions and making the clinical management than actually counseling parents. But I think we have to see that this is an essential part of our vocation. This is an essential part of what our job entails. And I've absolutely no doubt that if we do it well, it actually has long-term positive outcomes. And if we do it badly, it has long-term negative outcomes. And I saw in my own clinical career how both of those things, I saw how when the parent had been, when it had been explained in a really positive way, in a helpful way, that really helped the parents in the way in their attitude to their child. But I also saw the negative side, and that is that if parents had had a very negative counseling experience, then it led to long-term negative effects in the way they. And one of the things you need to remember is that parents sometimes have very, very often extremely good recall for exactly the words that are used in some of these conversations. And they may say years later, you know, the doctor said he was never walk, or the doctor said he was like a vegetable. And those words have stayed in their mind and been memorized and rehearsed and thought through, sometimes for years later, even though the neonatologists themselves might have completely forgotten what they actually said. And it may have not meant it in the first place. It was just, it came out in a not very helpful way and all the rest, but nonetheless. So we just have to remember how significant these conversations are, and therefore how careful we have to be in the way that we manage them. So if we know that we're going to, let's imagine that we've got a preterm baby on the unit, and it shows a high risk scan. It shows a hemorrhagic infarct, a grade 4 hemorrhage, and a poor encephalic cyst, say. So how am I going to discuss this with the parents? And so the first thing to say is to choose the setting carefully. Absolutely the worst place to have this conversation is on the NICU by the incubator and with other people listening. So having a dedicated conversation space or bad news room is really important. And you want to try and make sure that that place is quiet, that it's private, that it's pleasant, that you're not going to be interrupted, that it's a place where you can express emotion privately without feeling embarrassed, and so on. So, and I think just making time thinking about the setting and making sure you have the right kind of setting is really important. And when we were having these kind of conversations, we used to put a special code on the door so that people would assign which other staff would know the meaning of, and that meant don't interrupt. There's a serious conversation going on. Second, wherever possible, you should speak to both parents. I think it's really bad practice to speak to one parent, particularly if you're communicating bad news, because you're then putting a greater burden on that parent to communicate to the other parent. So even if, for instance, they would say, well, I'm sorry, the other person's working or they're not here or so on, I would be quite strong and say, I need to speak to both parents, and you need to find a way to get them both together in the same room. If the mother is single and unsupported, then you need to find somebody else who's going to be there for the discussion. So I would say in that case, the best person is the grandmother or the grandparents, the mother's mother, and or else a very close friend. So you should ask the mother, who else do you want to come and support you? But it's very important by having another person there in the room. Now, both they can provide emotional support for the mother, but also they can hear what is said and act as a kind of objective memory in the conversation. And if necessary, they can act as a kind of advocate for the mother if the mother is so overwhelmed with grief or whatever. And then I think it's good practice to have a third person in the room who is usually a member of the nursing staff, but somebody who is there to support the mother, seen as a supportive, compassionate presence, particularly if there's bad news to communicate. The next thing is the importance of preparing in detail, because I'm afraid there were many examples where I didn't prepare properly. I went into the room, I started the conversation, then I suddenly discovered I was making mistakes. I mean, sometimes I hadn't worked out whether it was a boy or a girl. I used the wrong name. I didn't know the details of the family. I got the history wrong. I hadn't quite remembered the precise details of the scan. All those things normally you can get away with, but in this situation they are disastrous because they destroy the trust. You know, how can I trust you if you don't even know whether my child is a boy or a girl? You know, how can I trust you when you haven't got the details right? So taking the time to prepare, you know, even if it takes 10, 15, 20 minutes to go through the notes and remind yourself about the family history and the previous history and what the scan showed and what the progression of events was and all that, what the pregnancy was like. That I think that is a really important part of the process. And while you're preparing yourself, you may well want to prepare what kind of words am I going to use. So I think it's quite helpful to think in advance, how am I going to describe this scan? What words am I going to use? And also, how am I going to describe what the prognosis is? What particular words am I going to use? Because if I've thought through in advance what words I'm going to use, it's more likely that I'm going to be able to speak in a thoughtful and helpful way. If I'm just hoping that something will plop into my head at the moment when I'm there with the parents, I might well say something rather stupid or not particularly thoughtful. So that's why actually thinking in advance about the kind of words I'm going to use is helpful. And what we're aiming for when we're choosing words is this combination. We're aiming for, on the one hand, clarity, but on the other hand, sensitivity. And there tends to be a spectrum. You know, you get some people who speak and it's very, very clear, but it's quite brutal. You know, your baby is brain damaged. It's going to affect them for the rest of your life. You know, there's damage to this part of the brain. You know, it's clear, but it's brutal. But on the other extreme, you get people where, you know, well, we're on the one hand and on the other, and, you know, and we're doing the best, and it's all very, very soft, touchy-feely. But in the end, the parents don't understand what you're talking about. It's all too vague. And so we're trying to find words which are both clear, but at the same time, sensitive and compassionate. So starting off, having introduced yourself and explained what the purpose of this discussion is, I think the first important thing is that you express concern and compassion and empathy. You start off by saying, by showing that you understand this is a very difficult time. You know, we understand, I understand you must be very worried and concerned about your baby's been very sick. You know, we've been doing all these various tests, and I understand this is a really difficult time for you. And it's a difficult time for all of us, but I'm here to try to explain what we've found and what the implications are going to be. So something like that, express concern and compassion. And then, as I said before, I think this image of the jigsaw puzzle, I want to put together all the little pieces together. So instead of going straight at and saying, well, your baby had an ultrasound scan and it showed a large hemorrhage, that's not, I think, the way to do it, because immediately you have given the impression that all that matters is the scan. So my experience is the best way of managing these conversations is actually to go through the history together, chronologically. So what I would say is something like, what I'd like to do is just discuss with you all the things that happened to your baby. So the first thing that happened was the pregnancy was going on quite well and everything seemed okay, didn't it? Until we got to 22 weeks. And then at 22 weeks, then you had this difficulty, didn't you? And then you started going into labor. Is that right? And then you had to come into the hospital. Yeah, that's right. And then what happened? And then you had these, and then the baby was delivered. Okay, and so then we had a team present at the delivery, and the baby came out, and the baby was in quite good condition to begin with, but then developed these respiratory problems, and you know the baby then had to go on the breathing machine. And to begin with, the baby seemed very stable, but then we had this difficult period on the second day of life, and the blood pressure was very low. And you remember when we had to do blood transfusions, you sort of go through the history chronologically. This happened, and then this happened, and you get them to be part of this. You know, you check with them, is that right? And that must have been quite worrying for you, and so on. And then we did an ultrasound scan, and the ultrasound scan showed this. And then you're putting the ultrasound scan in the context of the overall clinical picture and the sequence of events. And the ultrasound scan showed that there was bleeding. Unfortunately, it shows that there's been bleeding in the center of the brain, and it starts in this region of the brain. And it may be helpful to have the image there and be able to show them where the germinal matrix starts and how the bleeding has gone into the scan, and just explaining about the scan. It isn't essential to have the pictures unless people ask to see them, but explaining in words, there's bleeding. I often use the phrase bruising because it doesn't sound quite so bad. Bruising in the center of the brain. And this has now spread and affected some of the connections in the brain, the part of the brain which is to do with connections. And unfortunately, we think it's very likely that that's going to have some kind of long-term consequences. And then I would discuss what those possible long-term consequences were. But I would avoid giving precise numerical statistics. I mean, telling someone their child has a 25% chance of having problems or a 60% chance of having problems, I mean, frankly, it doesn't. What does 60% mean? You know, my child is one person, and they either have problems or they don't, and knowing that it's 60% or 30% or doesn't really help. So I would tend to use figures like the majority of babies with this will have some kind of problem, or there's a small chance of problems, such as those kind of vague ones. But unless people were being really pushing me very hard, I wouldn't give precise numbers. And as I've said before, don't destroy hope, even with a high-risk lesion. So I would say, for instance, in the grade 4 hemorrhage, I would say something like, unfortunately, what our follow-up study shows is that the majority of babies who have this kind of picture on the scan will have some kind of problems or difficulty with movement later on in life. And I would then discuss the sort of things that would mean. But what I would point out is, first, there's a huge range. For instance, if it's a unilateral HPI, the most likely outcome is a contralateral hemiplegia, where the arm is more severely affected than the leg. And so I would, if necessary, and if they asked me to, talk about what it would be like for a child with a hemiplegia. And interestingly, actually, having seen many in the follow-up clinic, children with a hemiplegia often do remarkably well, because if you've got one good arm and one good hand, that means you can write, you can operate a computer, you can operate machinery. And if you've got one good leg, that means you can be mobile. And in most cases, even if you've got a very abnormal gait, you can get around reasonably well. So understanding the difference between a sort of unilateral HPI compared with, say, spastic diplegia, which you'd get following PVL, and being able to talk to people about what the implications might be for a child. But I would also say I might be wrong. We do know that some babies do incredibly well, even though the scan shows this. And therefore, I have to be honest with you. And to be honest, that's what we're hoping. We're hoping that your baby's going to do really well. But I have to warn you that there's quite a chance that this child is going to have problems. So what are we going to do? Well, what you mustn't leave people with bad news and then say, well, that's all we can do. I think what's really important is that you discuss the next steps. Before you end the conversation, you discuss what's going to happen next and what are we going to do to help you. And so that what it might be, well, the first thing is that I'm going to ask the nurses to stay with you here. And if you've got any comments or questions, you can give them to her and she can pass them on to me. The next thing is I want you to write down any questions or things you don't understand. And I'm going to come back and see you in 48 hours time. And we're going to have another conversation. We'll discuss then and go through things again. I'm going to ask the physio to come and talk to you about what exercises you can do with your child. We're going to refer her to the multidisciplinary team. And so you're mapping out what the steps are and the positive things that you could do. So I would emphasize, she's going to teach you, parents, how to do physio so that you can do the best things for your child and you can make a real difference. And then it's really important, as you walk out of the room, the temptation is to mop your brow and say, thank goodness that's finished, and I'll just go off and have a cup of tea. But actually, you mustn't do that. What you've now got to do is you've got to write a detailed account in the notes, because it's really important that the rest of the neonatal unit staff know what you've said and the words you've used and the language so that they can reinforce it. So you need to write down however you do this in some detail how the conversation went, what words you've used, and what the plan is looking forward. So here are some useful phrases that I've used and other people have used. Lots of parents think that we know exactly what's going to happen because we're clever doctors and we've got all this wonderful machinery and scans, but we're not telling them because we don't want to hurt them. And so you've actually got to explain, look, honestly, I can't tell you exactly what's going to happen. The best doctors in the world can't tell you what's going to happen. Nobody has the second sight. I would explain about how the brain adapts and grows after the child goes home, makes new connections. The most important thing is not what the scan shows, but how your baby develops in the future. So the fact that the scan is worrying does not mean that the baby's going to have a catastrophic future. What's most important is practically how the baby develops. In the end, we all want to do what is best for your baby. That's a useful phrase if we're talking about withdrawing intensive support as well. We're all trying to do the best. It's not that we're against your baby. It's not that we're trying to harm you, but we want to do the right thing. And your baby may prove us all wrong, and I really hope that she does. You know, in other words, you know, even though we're worried that the child's going to have adverse outcome, we may be wrong, and you're remaining giving people that hope. We won't focus on the scan. We'll focus on how your baby is doing and making sure that we give him the best possible care. And a famous phrase, sometimes we need to hope for the best, but prepare for the worst. You are the most important person for how your baby develops in the future. So you mustn't disempower the mother and disempower the parents. It's easy for them to think, you know, well, I'm not a neonatologist and I'm not a physiotherapist and I'm not a behavioral psychologist, so there's nothing I can do for my child. And you need to help them to see, on the contrary, as those statistics I said about maternal education show, you are the mother is the most important person for how the baby develops in the future. There are lots of other people who can provide input, but no one else can be a mother. And we're here to support and care for you and your baby. Whatever happens, we'll be here for you. And this is what not to say. I know how you feel, because the right answer to that, if you say that, is you don't know how I feel, doctor, and I hope to God you never do. So don't say, I know how you feel. Don't say, if we had known how bad the injury was going to be, we would never have resuscitated her. I've heard doctors say that to parents. Don't say, we all feel really guilty about how things have turned out. I mean, you may feel guilty, but don't do your psychotherapy on the patients, on the parents. If you feel really guilty, then you need to talk to your colleagues, or you need to go and talk to a counselor. But don't put your guilt on the parents. I've seen that happen many times, where doctors, because they felt guilty, they felt they had to sort of pass on their guilt onto the mother. But actually, it doesn't help. It doesn't help the mother to know that the doctor feels guilty. And don't make these confident negative predictions. I need to tell you that he'll never walk, he'll never talk, he'll never speak, he'll never have a normal life. You don't know that. The statistics can't tell you that. And you have no right to make those, to say those negative things. And just to finish, if you haven't seen this paper and read it, can I recommend it to you? It was in Acta Pediatrica 2014. And it was written by a group of parents of extremely prem babies. And it gives you the parent's perspective of having an extreme prem baby in a NICU. And it's very, very helpful. So this is some of the things they said. Our unborn children have a story and are part of our hopes and dreams. Do not use gestational age to categorize our child. Oh, you're the mother of the 23-weeker. My baby is not a 23-weeker. My baby has a name. Each baby is different. Have a personalized approach. You can tell us what generally happens to children about to be born at the same stage of gestation as our child, but please also describe to us the particularities of our child. That will influence his or her outcome. Each family is different. We disagree that every family needs to receive extensive information about everything negative that may happen. Some parents want statistics, others want the general pictures. Some parents want to make important decisions on their own, while others want recommendations. Please listen to us individually. We need to trust you. Do not tell us that babies at 22 or 23 weeks do not survive. Do not tell us that most preterm infants are disabled. We rely on you to know your data. Reflect on the differences between numbers and medical values. Do not tell parents that their child will have a negative impact on their family. You don't have the data to support these claims. Many clinicians decide that giving babies a chance is not worth it for a 10 to 20% survival rate. Our discussion should be about values and not about percentages. Do not take away the hope we have. There is always hope that we will deliver tomorrow. There is hope that we will be able to spend some time with our child. There is hope that we can survive the death of our child with positive memories. Do not abandon us. Instead, tell us that you'll be there, whatever happens. Okay, happy to respond to any thoughts or comments. You're muted, Alan.
Prof, I was going to ask a question. One of the things that sometimes we find ourselves in a situation where parents put the questions back to us and ask us about what we would do if we were in that situation. And I'm just curious, I mean, how do you approach that? Because clearly, we've never been in that situation, and it would be so judgmental for us to even say anything. I'm just curious to know your
yeah. Well, it's interesting, isn't it? I mean, I know that the received wisdom is that you should never answer that question, but actually I think that's wrong. I have answered that question sometimes. I think, again, you just have to take every case on its own merits, and you need to work out what is the relationship, what would be helpful. But there certainly are some situations. I mean, I think, what is the physician there for? Well, partly they're there for technical expertise, and for our expertise about prognosis and therapies and outcomes and risks and all that. But partly the physician is there to be a wise friend. And if you were in some completely different situation, I don't know, imagine you're about to buy a house or something like that, and there's this very complicated decision and you really don't know what to do, but you've got this guy who knows a great deal about houses and who is a good friend. I think it's perfectly reasonable to say, if you were in my situation, what would you do? And to give them an honest answer. So if that's true about any other area of life, why is it not true about medicine? So I think, of course, I would preface it by, to be honest, I've never been there. I've never had a baby at 24 weeks. I can't put myself totally in that position. But from everything I know, if I was in this situation, to be honest, this is what I would want. I'd want to have the best. I'd want to have maximal support because I know that babies can recover from this. Or, to be honest, I would want to stop treatment and give my baby comfort care. Now, somebody else might come to some other decision, but you've asked me and I've given you an honest answer. Now, I wouldn't always do that. In some situations, I would just say, I don't think that's appropriate. But there are situations where I feel being a wise friend means giving my honest personal opinion.
That's really helpful. Prof, I was also going to say that in some situations, sometimes we disagree with parents, and it might be about us talking about scans. There may be an element of denial that comes in. And I mean, really, it's never one conversation. Obviously, if we're worried about a particular outcome and we encounter that, what would your approach be in that situation? How important is, I mean, giving them hope is so important, but also the message that you might want to convey. And by no means is it certain. And that's another area that I really struggle with.
Yeah. Well, I think, again, it's all about trust, isn't it? It's building a relationship of trust. And I do understand that this is becoming more and more difficult. And actually, if I look across my career, I started working in neonates in the early 1980s. And just the difference between the 1980s and the 2020s, there has been such a loss of trust in authority figures. And a consultant is an authority figure. And I think it is hard to get people to trust you and to show them that you are trustworthy. And I think it's also been made much worse by the constant turnover of the staff. You see, so in my day, in the bad old days, we would have one of the attending neonatologists who was basically regarded as the attending neonatologist for 2 months at a time. and everybody knew who the attending person was, and every parent knew that that was the person who ultimately they had to talk to and who carried the can. And it was absolute hell going on for 2 months. But in terms of continuity of care, it meant that you were the ones who had the conversations. And the agreement with the other neonatologists was that although they would do the on-calls, they wouldn't take major management decisions wherever possible without the attending consultant. I think, unfortunately, these days, what you often get is people changing every 24 hours. And so the parents are exposed to a constant stream of a different doctor, a different doctor, a different doctor, a different doctor, and every doctor says a different thing. And how on earth can I trust you when you all say different things? And of course, from a parent's point of view, you can see that, can't you? How difficult it would be if a constant succession of strangers comes along. So I don't really know what the answer to that is. I do think my suggestion, and some places have tried to implement this, is that every long-term baby ought to have one nominated consultant who does all the communication. And unless that's absolutely essential, the serious communication is left to that named consultant for each baby, because I think there's that way of. So I think you've got to build trust. And then I think you've got to try to build up the relationship, and by showing that you're being honest, by showing that you're listening, by showing that you're prepared to have repeated conversations, that you're not going to try and pressurize or abuse, but that you're just trying to be straight, and by being honest about the things you don't know and the things you can't be certain about. And my experience was that in most cases it was possible with time to establish a relationship of trust. But it's not 100%. And sometimes you just find that for whatever reason, we cannot establish a relationship of trust. And I think in that case, then you should say, well, we're clearly not doing very well. Can I suggest another doctor who's going to manage your baby and take these decisions, and you can discuss them with them. So I do think you have to be prepared for that. And I do think that asking for a second opinion, asking for someone independent to come and explaining, that obviously you're finding it difficult to accept this, and therefore you ask for somebody quite independent to come and talk. And I think that can help. But yeah, I don't know if that's helpful. It just sort of.
That is really helpful. I think, especially in our times, as you've said, with the media as well, it's a real challenge. Parents are very well informed, and I would say potential of disinformation is also exists. So completely accept that. One of my other questions was around anger, and obviously with any information that we give to parents, there's always an element of our nonverbal skills that come into it. And clearly, sometimes information can be conveyed in a way that makes parents angry. And I'm just curious, how have you approached that?
I do think that when parents become very angry, it is one of the hardest things to take, particularly when you feel that you have put an extraordinary amount of time and energy and care to do the baby, and then you just get hostility and anger, and I think that's very hard to take as a professional. But I'm afraid I think you just have to accept that this is part of the it goes along with the territory, and that most of the time people are responding with anger. Actually, it's out of their own emotions and fear and concern, much more than that it's actually not really directed at you, even though they may express it as being angry at you. You just have to try to distance yourself from it and say, these people are just very distressed and very frightened, and they're just taking it out. It's like they're lashing out. And I'm afraid you just have to take it and show that you don't take it personally. And I think the phrase, "I understand this is very difficult for you," I think you just have to keep saying this. I understand this is difficult, and maybe let's have a timeout and let's allow tempers to cool down and so on. But I think this is where it's important for us as neonatologists and as physicians to have our own support network. I think every one of us needs to have others where we can just go and talk about how difficult it's been and about our own emotional responses. But as I say, we shouldn't take it out on the parents. We shouldn't try and do our own psychotherapy on the parents. We have to, in a sense, to absorb this from the parents, and then we go and do it elsewhere. But we do need to make sure that there is that kind of supportive network where other people who understand, where we can put out our frustrations and the negative feelings and so on.
So I'm just going to open the floor to the audience. Sorry, I interrupted you, Prof.
No, just the other thing I think is that I think we should be looking for the signs of burnout. Neonatology is a very intense specialty, and all of us are capable of becoming burnt out. And we need to recognize what are the signs of burnout. And I think for me, the most important signs of burnout is compassion fatigue. It's when actually, I know this is all very sad and all the rest, but frankly, I don't give a damn. Once I start feeling like that, this kind of blunting of my feelings and my empathy, that's a real warning sign that I'm getting burnt out. And actually, the only cure for burnout is you have to have a break. You have to get out of the NICU and spend a time, for recuperation. And I think sometimes we need to have systems where we should rotate people. You spend a time working in NICU, but then you need to be rotated out and to have a period of recovery in some other area, so to avoid this just continual burnout.
So I'd just like to invite any questions from the audience. So I've got a question from one of my colleagues, which has come through over YouTube. And his question is about the situation of using a room. And one of his comments is that sometimes the Breaking Bad newsroom becomes an area of worry for the parents because we're taking them back to that room. And, it's something that I've encountered as well. We have a green room in our hospital where I think our biggest challenge is sometimes the first conversation is obviously not good news. And then when we say we're going back to the green room for further conversations, it becomes tricky. And I mean, have you been in that situation? How have you approached it?
Yeah, that's really interesting, isn't it? And I you can see why that happens. People do become traumatized by a particular setting. And maybe we just need to be flexible and think, well, okay, if this is a very painful setting, can we find some other place? Maybe an office, maybe, somewhere else, somewhere in outpatients. I think we can be flexible and recognize that certain settings, certain reminders may be very triggering for people and very unpleasant. So again, it's trying to see it through the parent's eyes. The whole art is empathy, trying to see it through their eyes instead of just through our own experience. And I think so often we fail because all we can do is just see it through our own eyes, and we find it impossible to imagine what it's like for parents. And there's no doubt, I think, it must be one of the worst experiences possible to be, to us, a NICU is a completely normal, routine environment, but for them, a NICU is a bizarre, terrifying, place where these little babies teeter between life and death, and where terrible things are happening, and my child might be permanently damaged, and events happen from moment to moment. So you can see how profoundly traumatizing it can be for parents, and I think we just need to support them. But interestingly, this comes back to the not destroying hope. You see, one of the things I realized over the years, you get some parents who are so filled with anxiety, and they keep asking you, but what about, could you explain to me how the mechanism of PVL, could you explain to me where on the scan the damage is? And the more time we spend explaining about mechanisms of brain damage and white matter and long-term outcome and so on, all we're doing is we're just feeding this anxiety. And I think we're not necessarily helping a great deal. Whereas the other parents, I meet other parents who say, well, I hear what you say, doctor, but I think she's a little fighter and I think she's going to be all right. And what I find is that emotionally, you might think that's denial, but actually those people often do emotionally so much better. And they may well be right. It might turn out that she was a little fighter and that she did a lot better, despite the fact there was PVL there. So it's trying to support the parents emotionally through this experience and recognize that a certain amount of denial is absolutely essential. I mean, as a parent, for those of you who are parents, you know that we all have denial about our kids. If we were ruthlessly honest about quite how awful all our kids were and all their problems and so on, what kind of parents would we be? But, we look at our children and we say, well, they have all these problems, but you know what? I love them. I love her, and she's wonderful. And that's part of being a parent. So why are we destroying that proper kind of denial in our parents?
That is so helpful, Prof. I can't thank you enough for having taken this session for us. I mean, each time I've been able to hear you speak, there is everything, certain pearls of wisdom that I take back that, to this date have actually helped me in situations and have been very formative in my development as a consultant neonatologist. I would like to thank you on behalf of, my colleagues, the network, and all the participants who are here today. And I mean, just to give you a little bit of a flavor, we had a total of 69 today. And this is from virtually every continent, including Africa. So I can't thank you enough for being with us. And, I'm hoping that, at some point we might be able to come back to you for more.
Yeah. No, absolutely. Yes, please do. And I'll share my PowerPoints. So if please, if you'd like to just circulate the PowerPoint. I don't think it's got any, I'm just thinking, has it got any images of babies? I don't think it has. I think therefore there's nothing therefore that I would be worried about from a confidentiality point of view. So please feel free to use it. And in case you're interested, I have a website, johnwyatt.com. It has some neonatal content on there, as well as quite a lot of other ethical and philosophical stuff. Great, thank you so much.
We're grateful.
It's very good to, and greetings to all you across the world. It's amazing, this technology, and it's wonderful to be part of it.
Thank you.
Thanks then, I'll leave. Goodbye.